Good morning, Ministry of Health. Firstly, we would just like to thank you in allowing us to present our topic of interest of puerperal sepsis. So a little bit about us. We are the White Ribbon Alliance. We're a non-government organisation that was established in 2009 to help provide a voice for those who are at high risk of mortality throughout childbirth. It allows local citizens of Uganda to work together with local and national officials to ensure that they can be cared for in health centres. The mission statement is to have a people-led movement to allow women and children their right to quality reproductive, maternal, newborn health and their rights. This here is our dashboard. The What Women Want dashboard is a tool that we utilised to ask women themselves and what they request for quality and reproductive maternal care. Two key factors of this was water, sanitation and hygiene, known as WASH, targeting and improving cleanliness and functional toilets, hand washing and safe waste disposal for facilities, and respectful and dignified healthcare. This consisted of wanting universal rights for mothers and newborns.
So what is puerperal sepsis? Well, the World Health Organization defines puerperal sepsis as an infection of the genital tract occurring at any time between the rupture of the membranes or labour and the 42nd day postpartum, in which two or more of the following are present: fever, an oral temperature of 38.5 degrees Celsius or higher on any occasion; pelvic pain, abnormal vaginal discharge, for example, the presence of pus or abnormal odour of discharge; delay in the reduction of the size of the uterus, for example, less than 2 centimetres per day during the first 8 days; and dizziness and collapse. So just for a little bit of background, sub-Saharan Africa has the highest burden of maternal mortality worldwide, and puerperal sepsis is a leading cause of maternal deaths, accounting for approximately 10.7%. The Lancet GLOS study, Global Causes of Maternal Death, a World Health Organization systematic analysis, showed clear differences globally, with the highest burden in low and middle income countries compared with high income countries. Now, despite puerperal sepsis being a major health burden in sub-Saharan Africa, it is largely treatable, preventable, and measures can be taken to reduce the risk of sepsis and adverse outcomes. A variety of agents can cause puerperal sepsis. The most common bacterial pathogens include E. coli and group A streptococcus, and some of the others listed on the slide here. Here are some of the most common risk factors leading to puerperal sepsis. So, caesarean section, a prolonged labour lasting more than 12 hours, premature rupture of membranes for prolonged period, frequent vaginal examinations during labour, for example, more than 5, particularly in unsterilised circumstances, damaged and dead skin tissue, for example, as a result of traumatic delivery, fragments of placenta remaining in the womb after delivery, poor standards of hand washing and general hygiene in the days following delivery, and some other predisposing factors include anemia and poor nutrition. Importantly, there are social and community risk factors which increase the woman's risk of developing puerperal sepsis, such as delivery by an untrained birth attendant, lack of transportation and or long distance from a woman's house to the health facility, financial constraints, lack of public awareness and health knowledge for recognizing the signs and symptoms of puerperal sepsis, availability of postnatal care, as well as cultural and gender differences which may delay help-seeking behaviour. Influencing factors include power relations, structural positions and age hierarchies, culturally prescribed gender roles, or economic factors apart from cultural context. The best practice management of puerperal sepsis I'm going to discuss now is based on the World Health Organization's recommendations for the prevention and treatment of maternal peripartum infections and the Royal College of Obstetricians and Gynecologists guidelines for bacterial sepsis following pregnancy. So if puerperal sepsis is suspected, early hospital admission and prompt treatment with a combination of high dose, broad spectrum and intravenous antibiotics may be life-saving. Monitoring and observations of all vital signs, including temperature, pulse rate, blood pressure, and respiratory rate of the woman with suspected sepsis should be carried out every 2 hours. Antibiotic treatment, we're looking at administration of IV antibiotics within 1 hour of suspicion of sepsis with or without septic shock. And a combination of clindamycin and gentamicin is recommended as first-line antibiotics for the treatment of puerperal sepsis. Blood cultures are the key investigation and should be obtained prior to antibiotic administration. However, antibiotic treatment should be started without waiting for microbiology results. Features of severe sepsis and the presence of shock or other organ dysfunction in the woman indicates a need for admission to intensive care unit where possible, as severe sepsis with acute organ dysfunction has a mortality rate of 20 to 40%, rising to around 60% if septicemic shock develops. Despite being highly preventable, puerperal sepsis continues to be a major cause of death and morbidity for women. So what can we do to reduce the risk of sepsis? Well, we need access to clean water and sanitation, as well as good hygiene practices, access to quality care during pregnancy and birth, responsible and timely access to the right medicines, proper infection prevention and control in hospitals and health facilities, increase public awareness and health knowledge, plus adequate training for health workers to be able to recognize the signs and symptoms of sepsis and be skilled in effective treatment. And for women undergoing elective or emergency cesarean section, routine antibiotic prophylaxis is also recommended. As we know, infection incidence is higher in low resource settings, and many of the maternal deaths are preventable. In low and middle income countries, like Uganda, risk factors are inadequately defined due to environmental, patient, and healthcare system factors. Additionally, the majority of published research from low resource settings don't include microbiological confirmation of infection. In a retrospective study from Uganda, puerperal sepsis accounted for 31% of all maternal deaths at that facility, making it the leading cause of maternal mortality. The United Nations Millennium Development Goal 5 addressed the need to improve maternal health, particularly seeing a reduction of maternal mortality by 75% between years 1990 and 2015. In 1990, the maternal mortality ratio for Uganda was 550 per 100,000 live births. Today, the Sustainable Development Goals address the need to improve maternal health in Target 3.1. By 2030, reduce the global maternal mortality ratio to less than 70 per 100,000 live births. However, the current maternal mortality ratio in Uganda is 336 per 100,000, only a slight improvement from 550 recorded in 1990.
So in case anybody in the audience is unfamiliar with Uganda, here's a brief introduction. It's a landlocked country in Central Africa with a population of approximately 41.5 million, though that is estimated to rise to 100 million by the year 2050. Most of the population live rurally, and even those that do live in the urban areas live in pretty poor conditions. Most houses are very basic without running water, sanitation facilities, or electricity. Uganda gained independence in 1962 and has had a very troubled history since then. Democracy, human rights, and the economy have been very slow to improve, and the gains that have been made have been undone by the COVID-19 pandemic. As can be seen from these statistics, including several high mortality rates, much is still needed to be done in Uganda to improve the health of the population. Uganda has a decentralized healthcare system. The Central Ministry of Health has overall responsibility for 112 district health teams. Each team is managed by a district health officer and is responsible for its own budgeting, planning, and service provision. Healthcare is supposedly free, but often payment is requested and therefore is financially unavailable to many Ugandans. There are many non-for-profit organisations running alongside the public health system providing healthcare in the country. As this chart shows, the healthcare system has a pyramid structure serving increasing numbers of the community. At the first level, there are village health teams. These are staffed by untrained volunteers, but often there are none, and there are generally no medications available. There are then 3 levels of health centres. These provide more and more clinical services and are supposedly staffed by increasingly qualified healthcare professionals. More often than not, however, this is not the case. For example, the health centre level 4 should be run by a senior clinical officer, meaning a highly qualified doctor, but more often than not, it is just run by nurses and some basically trained nursing assistants. It is at this level that emergency operations are supposed to be able to be carried out. However, this is obviously not possible without doctors being present. At the top of the pyramid, there are district and regional hospitals, as well as the National Referral Hospital in Kampala, which is where the country's few specialist physicians do work. As alluded to on the previous slide, Uganda's healthcare system is in a rather dire state. There are only 1.68 medical doctors for every 10,000 of the population. This falls well short of the WHO's recommendation of 10 doctors for every 10,000 population. There is a similar story with the numbers of nurses, midwives, hospitals, and hospital beds.
I'd like to take some time now to talk a little bit about one of the most pressing challenges facing Uganda's healthcare system currently. Despite the substantial disease burden, nearly 30% of graduating physicians in Uganda choose to emigrate each year. Medical brain drain refers to the human resource crisis in healthcare systems of many low and middle income countries, where new medical graduates choose to leave their country after receiving their education, resulting in a severe shortage of health workers. To make matters worse, the Ugandan Foreign Ministry is actively advertising opportunities for healthcare workers to go elsewhere, and the current situation will only worsen if nothing is done to incentivize health workers to stay in Uganda. As it stands, the current situation for Uganda's healthcare system is dire, under-resourced, filled with departures, and on average there are 16 maternal deaths daily. So why is all of this important? Well, as we know, as one of the most common maternal infections, puerperal sepsis accounts for approximately 10.7% of all maternal deaths globally, although it is largely preventable and treatable. Low and middle income countries suffer disproportionately from this burden, with sub-Saharan Africa having the highest burden of maternal mortality worldwide. The Lancet GLOS study suggests that current levels of monitoring and care across health facilities are not enough to prevent, identify, and treat levels of maternal infection effectively. Reducing maternal deaths caused by puerperal sepsis is vital to achieving the Sustainable Development Goals target 3.1 by 2030, reduce the global maternal mortality ratio to less than 70 per 100,000 live births. Implementing the UN Global Strategy for Women's, Children's and Adolescents' Health, and for the strategies towards ending preventable maternal mortality.
So looking at the case studies in Uganda, despite the evidence gap, there has been a few publications. The maternal waiting home is a concept that's currently being used by 2 private NGOs, AWARE and BCH. They both have access to skilled community midwives and trained community health workers. Additionally, BCH has got access to a full-time nurse, fully equipped theatre, and a 24/7 obstetrician cover. And on the right-hand side is the SMGL initiative, which is a multi-partner government-led initiative which has been designed to reduce maternal mortality mortality through community and facility evidence-based intervention and district-wide health system strengthening that could reduce delays to appropriate obstetric care. So this focuses on the 3 delays, and these include initiatives such as distribution of mama kits and training of the skilled birth attendants. So if you have a look at the health impacts of these 2 case studies, there's certainly been increase in utilization of the waiting hostel by the women, increase in average deliveries, increase in training of the skilled attendants, increase in outreach programs, but for certain, a definite decrease in the maternal and perinatal mortality. So main key lessons from these 2 case studies are that maternal waiting homes definitely work, particularly for high-risk pregnant women in remote areas. Definitely recommended in national and global health policies. However, they are almost non-existent in Uganda. And we know that maternal waiting home can contribute to increasing institutional deliveries, reducing obstetric delays, and improving maternal and perinatal health outcomes in remote areas. But the biggest health impact was definitely seen through the SMGL initiative, where there has been a noted 20% decline in maternal mortality, 28%, particularly during the postpartum period, availability of access to 24/7 delivery care, availability of life-saving medication during the postpartum period. So medication like oxytocin is more available, increase in the practice of the 3rd phase of the labor, so which is almost universal to a significant 90%. But more than that, there has also been an improvement in increased infrastructure and delivery care and other access to cares in the different types of the SMGL districts. So what this shows is that the parallel improvement of the supply and demand side for obstetric services, coupled with improved quality of care at facilities, together with a comprehensive district system strengthening approach, definitely leads to reduction in the 3 delays.
What can we do next? Well, our vision is that our interventions will contribute to the Sustainable Development Goals by developing solutions to reduce maternal deaths from puerperal sepsis. Our goal is to accelerate the reduction of preventable maternal deaths caused by or related to puerperal sepsis. Our objectives are to raise awareness about puerperal sepsis among healthcare providers, policymakers, and the public, and to develop and test effective strategies to prevent, identify, and successfully treat puerperal sepsis. Our priority areas of work are strengthening healthcare by training traditional birth attendants, providing safe birthing kits, research development and evidence generation, improving WASH, and global advocacy.
The first component of our intervention would be to train traditional birth attendants, as women prefer them over hospital staff, as they have found them to be disrespectful, as they don't provide a supportive environment to give birth in. And there is also a shortage of doctors and midwives, where women have had to give birth alone without professional assistance. Evidence around training traditional birth attendants has been conducted since the 1980s, but there's been a push towards women giving birth in health facilities, where some countries like Zambia have introduced a ban on them to become a more supportive role than managing the births themselves. However, traditional birth attendants still conduct deliveries despite these bans, which has divided the evidence, as their presence at birth have provided both positive and negative outcomes for the mother. The Brown Button Foundation, a Nigerian NGO, has assisted in training 5,200 traditional birth attendants and have focused their training on basic hygiene and providing sterile supplies through birthing kits. The second component of our intervention would be to provide birthing kits to promote the use of sterile supplies being used during deliveries with a combination of education. Brown Button Foundation has developed a birthing kit that provides a variety of sterile supplies such as gloves, antiseptics, surgical blades, and scissors, which prevents traditional birth attendants from using dirty and rusty supplies that can harm the mother. This birthing kit has led to the increase in using sterile supplies and education for traditional birth attendants to understand the importance of using sterile supplies for the safety of the mother.
Next, I'll talk about the feasibility of our interventions. For training traditional birth attendants, firstly, birth at home is still common in Uganda, and more than half of home births are attended by traditional birth attendants. Secondly, the emphasis of our intervention should be on motivating the younger TBAs and those who perform the greatest number of deliveries. Then the training program should be simple and emphasize only those basic scientific midwifery skills which can help the TBAs gain self-confidence and make deliveries safe and hygiene. Finally, training TBAs can alleviate the inconvenience of medical treatment and insufficient medical resources caused by distance. For the provision of safe birthing kits, its feasibility is mainly reflected in the following aspects. Firstly, the obtaining of safe birthing kits are relatively easy and low in cost. Some of them are fully subsidized or partially subsidized by NGOs. Thus, providing safe birthing kits for midwives and trained TBAs is very cost-effective. Then the use of safe birthing kits is not complicated. TBAs can master the use of drugs and medical supplies in the kit after being trained, so as to reduce bacterial infections during delivery as much as possible through skilled operations. Finally, the safe birthing kits are easy to be transported and stored, and are also disposable. Thus, they can be easily transported to rural and remote areas and can play a good role in the situation of lack of local medical resources and shortage of medical staffs. We have a plan to evaluate our interventions. This slide shows a qualitative study to provide contextual information about how safe birthing kits help various types of birth attendants maintaining the principle of clean delivery. This slide uses the safe delivery kit as an example to show how we can measure the effectiveness of our intervention through a cross-sectional study.
The list of cross-cutting issues for Uganda is sadly very long. Gender discrimination is common in Uganda, creating safety and equity issues for women and the children in their care. The populations and cities are growing so fast the systems cannot keep pace, and youth are being left unemployed. This gives rise to civil unrest without good governance. Children are part of an international vaccination drive but still suffer significantly from poverty and malnutrition. HIV/AIDS has left no family untouched. Everybody knows someone or is related to someone who has had it. Life is hard enough in Uganda, let alone for the disabled. There are no systems to support the disabled people. Human rights and sustainable development goals seem a faraway reach for Ugandan people at this point in time. We'd like to change that. Climate change will bring about new issues. Along with urbanisation and climate change, we will see new vector diseases and new food insecurity issues. Wash and sanitation matters are very critical to health anywhere in the world. Ugandan people sadly lack on both of these issues. We undertook an analysis of UNICEF worldwide data from 2016 that compared many aspects of women and children's health. When we looked at the report, we looked at postnatal, antenatal care, whether someone had the baby at home or in a facility, whether a birthing attendant was present or not, the type of birth, caesarean or natural birth. What we discovered was these factors had very little correlation between outcomes of maternal deaths. So we looked a little bit further, and what we came up with was a huge correlation between water and maternal outcomes. The countries that fared better had access to clean, safe drinking water. But that wasn't as significant as the findings of wash facilities. Every country in the top 10 or even 20 countries on that list for worst maternal health outcomes had less than 20% wash facilities across the country on average. This told us that wash is critical to good outcomes. Without water and wash facilities for sanitation and hygiene, any program that's implemented is doomed to fail. It needs to be implemented and integrated with every and any project to help women.
All right, we're going to move on to public communication from the Ministry of Health about maternal sepsis, and the focus will really be on health promotion, covering aspects of the disease, the intervention, and any prevention techniques as well. So health promotion should really be viewed through the lens of the Ottawa Charter, and the Ugandan health promotion strategy currently utilises it. And some of the really good strengths that come out of it is this concept of health inspectors, which has been established since as early as 1940s, and they go into communities and actually look at individual houses and make sure they've got safe toilets, safe hygiene, safe wastewater production, things like that. The the movement towards them being more community-based and looking at communal areas and public hygiene has also been a bit of a move in the last few decades. The second strength they have is this adoption of primary healthcare system approach, moving away from the colonial facility-driven healthcare and moving towards community-driven healthcare. The challenge there is the community-driven healthcare is often very under-resourced in Uganda and can actually have very subpar quality. Some of the other challenges that they face in health promotion is the subnational promotion system, whereby you've got individual provinces navigating their own health promotion within the communities and lack of coordination between them, and often lack of funding and governance from the national body. The coordination extends to individual stakeholders as well. So you've got NGOs, civil society organizations, and other stakeholders who are doing their independent programs about health promotion and often have no coordination amongst each other. So you've got duplication of efforts, you've got duplication of funding, and really conflicting messages that the public gets, and often results in mistrust in health promotion activities. The top to bottom approach of healthcare and the lack of community involvement in health promotion systems is also another challenge that can be addressed. So despite there being very little evidence-based strategies in the literature, there have been some success stories within the Ugandan context. One of the major ones was their HIV pandemic back in the 1980s. And what they found was their use of multi-sectoral, multidisciplinary approach really hammered getting that message across to the public. There was a coordinated effort amongst healthcare workers, among marketing agents, among television personalities, and it really reduced the confusion and the conflicting messages that the public was receiving. The other success story was the establishment of the National Immunization Program, where they used a consistent multimodal mass media campaign, utilizing your television posters, drama, social media messages, texts, to get the message across. And a lot of this was, culturally appropriate, local language was used, and really generated public interest. The last few ones are the sort of community healthcare worker involvement and community leader involvement, which really play a big role in empowering the community and mobilizing individuals within a community to promote their own health and sort of develop self-help techniques. There's local innovations and customization of health promotion systems can also occur that are acceptable to each community. And the last is village health teams, which have been established in Uganda for a long time, and they help sort of reach distant communities, so outreach to distant communities where normally you would not get a reach of public healthcare messages, and that also helps identify patients who are at high risk, and in this case, women who are high risk of puerperal sepsis, and get them to seek help early. So by utilizing the techniques and the strategies that have been effective in the past, so using your multimodal forms of health education programs, we really need to be telling the public about, what maternal sepsis is, what the symptoms are, who's at risk, how to prevent it, and really using and targeting the health literacy, using community members, using local slang, using culturally appropriate knowledge base, using religious leaders if required, and addressing the stigma that's around maternal sepsis. And one of the ways this can be done is by using sort of success stories from women who have survived or who have lived through maternal sepsis previously. So health education about prevention and intervention should really focus on the techniques that we've discussed before. For the first intervention of training of traditional birth attendants, it should be communicated to the public, that they're equipped with unique resources, they're trained by experts in the field, and have an increased knowledge base that makes it quite safe, in fact safer for them and their child as well. The second intervention is the birthing kits. One of the key things is to explain what the contents of the birthing kits are, particularly because a lot of these women have probably never seen or used the contents of the birthing kit before, and to really increase the trust in those equipment is critical. To tell them about the availability and accessibility of these kits, where they can find them and how they can use them at home, especially if they're having home births. And sample provision of free samples is something that can really help tackle this issue. And finally, promoting prevention techniques. So using your wash and your general hygiene promotion techniques can also be utilized.